Hi guys, welcome to my YouTube channel. Today in this video we want to talk about the causes, symptoms, diagnosis and treatment of urinary tract infections. As we all know, Pseudomonas is one of the most important nosocomial pathogens. This bacteria are responsible for a variety of infections with limited therapeutic options because of its antibiotic resistance. It can become life-threatening, especially when this bacteria are resistant to carbapenems like meropenem and imipenems. Pseudomonas aeruginosa is the third most common pathogen associated with hospital-acquired catheter-associated UTIs. You know that many patients use urinary catheters during hospitalization. UTIs due to Pseudomonas aeruginosa generally occur as a complication of number 1, a catheter in the urinary tract, an obstruction or a stone in the genital urinary system, and urinary tract instrumentation like cystoscopy procedures and surgery. In this slide, we discuss Pseudomonas aeruginosa virulence factors involved in UTI. The first factor is Lassa B, also known as elastase B. This is a zinc metalloprotease. This factor plays a role in tissue destruction through degrading elastin, fibrin, and laminin and other components of the extracellular matrix. Also, it causes immune invasion and biofilm formation in Pseudomonas aeruginosa strains. The second factor is PLCH that causes cell membrane disruption through hydrolyzing of sphingomyelin and phosphatidylcholine and phosphatidylserine and phosphatidylcholine. By breaking down phospholipids in host tissue, PLCH facilitates bacterial invasion and spread. And also, its hemolytic activity could aid iron availability in the iron-secreted urinary tract. The third factor is type 4 Bacterial Biogenesis protein PIL-B. It helps P. aeruginosa infection through motility as revealed from its name. Swarming motility requires multicellular coordination of bacteria across semi-solid surfaces, including mucosal sites. The last and the crucial one is exoenzyme S. This factor injected into host cells via the type 3 secretion system. N-terminal domain of this protein causes inactivate host GTPase and disrupts cytoskeleton that leading to cell rounding and loss of cell shape and adhesion. C-terminal domain have ADP ribosylate activity that leads to inhibition of intracellular signaling and induction of apoptosis. Also, exos S could aid persistence and immune invasion. As we all know, biofilm formation, especially on the surface of foreign bodies like shunt or catheters, plays a key role in UTI. Growth of P. aeruginosa begins in the form of macrocolonies, which later coalesce together to form biofilms. Alginate, which is an acetate polymer of beta-dimanoric acid and alpha-L-glucuronic acids, is the most important component of Pseudomonas aeruginosa biofilms. In P. aeruginosa, two types of quorum sensing systems, LAS and RHL, have been reported, which have an important role in virulence and pathogenicity of P. aeruginosa in UTIs. We know quorum sensing systems are vital for bacteria to communicate and biofilm formation. For identify of UTI etiology, an urine sample from the patient is sent to the laboratory. In lab, the infectious agent is diagnosed through a series of tests like biochemical tests. In next step, based on guidelines like CLSI, some antibiotics are chosen for checking antibiotic activity against the cause of infection. Examining antibiotic sensitivity is done using different methods such as antibiogram, e-test, and automated systems. And finally, the best antibiotic choices are reported to physicians. In the field of Pseudomonas infections, antibiotic choices can be very limited due its high resistance to many antibiotics, and in many cases may need a combination therapy. For Pseudomonas infection, we can have a combination of an anti-pseudomonal beta-lactam, example penicillin or cephalosporin, and an aminoglycosid. Carbapenems like imipenem or meropenem with anti-pseudomonal quinones may be used in conjunction with an aminoglycosid. The second cause of bacterial UTI we discuss about today is Mycoplasma genitalium. Mycoplasma genitalium is a facultative anaerobic organism and a recognized cause of non-gonococcal urethritis in men. The global prevalence of M. genitalium among symptomatic and asymptomatic sexually active women range between 1 and 6.4%. M. genitalium has been associated with increased susceptibility to HIV infection by infecting the epithelial layer, reducing its integrity and activating HIV cell targets beyond the epithelial layer, thereby promoting transmission and reproduction within the host and increasing viral shedding through mucosal surfaces. All Mycoplasma species has been associated with perinatal morbidity and mortality. M. genitalium infection among women are also frequently asymptomatic, and the consequences associated with asymptomatic M. genitalium infection are unknown. M. genitalium causes symptomatic and asymptomatic urethritis among men, and it is the etiology of approximately 15 to 20 of NGU, non-gonococcal urethritis, 20% to 25% of non-chlamydial non-gonococcal urethritis, and 40% of persistent or recurrent urethritis. M. genitalium co-infection with Chlamydia trachomatis has been also been recognized. In this slide, we talk about clinical manifestations of Mycoplasma genitalium. Number one is pelvic inflammatory disease or PID. Female urethritis, male urethritis, cervicitis, infertility. M. genitalium has been isolated from samples of semen and has been observed attaching to the human spermatozoa. Number 6 is spontaneous abortion, adverse breast outcomes, and number 8 is melanopostitis and prostatitis. Genitalium was significantly associated with balanitis or prostatitis, collectively termed balanopostatitis. For treatment, Mycoplasma genitalium infection, two-stage therapy approaches, ideally using resistance-guided therapy, are recommended for treatment. However, it requires access to macrolide resistant testing. If M-genitalium resistant testing is not available and M-genitalium is detected by a nucleic acid amplification test, doxycycline and with combination with moxifloxacin can be effective. But if M-genitalium resistant testing is available and and the strain is macrolide sensitive, doxycycline with a combination azithromycin can be effective. But if macrolide resistance, doxycycline and moxifloxacin can be effective. Second cause of bacterial UTI is Mycoplasma hominis. This bacteria can frequently be recovered from the lower genitourinary tract in men and women, but is not thought to cause cystitis, epididymitis, and prostatitis. However, it can cause acute pyelonephritis, especially after instrumentation or if obstruction is present. Colonization rates for genital mycoplasmas range between 60 and 80% worldwide, with Mycoplasma hominis colonization rates being reported to be 21 to 53. Mycoplasma hominis can cause a variety of infections like postpartum and post-abortal fever. 10% of cases of postpartum and post-abortal fever are related to the presence of M. hominis. Number 2 is chorioamnionitis. Chorioamnionitis is an infection of the placenta and the amniotic fluid. Mycoplasma hominis has been isolated from women with premature labor and chorioamnionitis, and from 30% of children with breast weight below 2,500 grams who were born by cesarean section with intact membranes. Number 3, pelvic inflammatory disease. Mycoplasma hominis has been isolated from the fallopian tubes of women with salpingiitis and in whom antibody response could be established. Salpingiitis is inflammation of the fallopian tubes caused by bacterial infection. In this case, bacterial infection is Mycoplasma hominis. Mycoplasma hominis can cause infertility. Mycoplasma hominis can affect different parts of the female reproductive tract and can lead to infertility. Also, it can lead to male infertility as shown by studies. Also, Mycoplasma hominis can cause some pregnancy outcomes. Mycoplasma hominis can be transmitted from the infected mother to the fetus and newborn by 3 different routes. Number 1, infection gaining access to the amniotic sac. Number 2, hematogenesis route via involvement of the umbilical vessels in placental infection. And number 3, acquisition of this organism by the neonate while passaging through an infected parental breast canal. Mycoplasma hominis has been suggested as a possible cause of respiratory distress and pneumonia in neonates. Hominis is also associated with bacteremia in neonates. It is because of this type of infection that prenatal tests, especially in natural child births, are essential. We are 3 different methods for detection Mycoplasma hominis infection. Number 1 is culture. Culture is considered the gold standard for detection of Mycoplasma hominis. The commonly used medium for isolating Mycoplasma hominis is the PPLO brush and agar containing arginine. Number 2 is molecular methods like PCR and NGS, next generation sequencing. These methods are 2 of the most reliable methods for detection Mycoplasma hominis. And number 3 is serological tests. Serological assays that have been used are immunofluorescence, metabolism inhibition, and enzyme immunoassay. Lipid-associated membrane protein was mainly used as the antigen in the serological assays. Treatment of Mycoplasma hominis infection. Tetracyclines have historically been the drug of choice for use against urogenital and systematic infection due to Mycoplasma hominis in adults. In locations and patient populations where tetracycline resistance or treatment failures are common, other drugs such as fluoroquinolones should be considered, guided by in vitro susceptibility data when possible. It is important to note that tetracycline carries several side effects in neonates and should be substituted with a safer alternative whenever possible. All therapeutic options presented in this video are based on established medical guidelines and are intended solely for educational purposes. They should not be considered as a treatment recommendations for individual patients. If you experience symptoms of infections such as purulent discharge, painful urination, increased frequency, or burning sensation, you should seek medical attention promptly. Take care of yourself until next week and our next video. Don't forget to subscribe to my YouTube channel for more updates.